Welcome to the Just Hard podcast, real nurses, real talk, real life, where we take the avalanche of chaos in your final exam study guides and turn it into something your brain can actually metabolize.
We're your hosts, Chelsea and Lisa, and today we are doing what every nursing student secretly wants, a final exam review that doesn't suck
Whoop whoop.
and includes deeply questionable pharmaceutical advertisements.
This episode isn't about memorizing everything. It's about recognizing patterns and thinking like a nurse.
Because your brain isn't failing you, it's just in nursing school, which is basically Fight Club with paperwork.
It's just hard, and you can do hard things.
We're going to start off with a review of the immune system in our final review episode today. So, Unit 1, Immune, Sepsis, Lupus, HIV, AIDS, and Cancer. Where the body starts fights it cannot finish.
Let's start with sepsis, my favorite topic, because if something in the hospital is going wrong, it's probably sepsis until proven otherwise. Sepsis is infection plus systemic inflammation and organ dysfunction. And the vital signs students forget? Hypothermia. Cold plus confusion is still sepsis.
The biggest concept is new organ dysfunction. Your cirrhosis patient being confused at baseline, not necessarily sepsis, so you've got to be a little bit of a detective, but suddenly getting more confused, that's your moment.
So let's talk about the 1 hour bundle. First thing you need to do, get blood cultures, start your broad spectrum antibiotics, give your 30 mils per kilogram fluid bolus, check your lactate, and add vasopressors if needed, meaning if your fluid bolus doesn't respond and lower that lactate, patient is still symptomatic, add vasopressors.
Yep, and that's the point where they progress from sepsis into that septic shock. Sepsis doesn't wait for anyone. Once you have the order, that broad spectrum antibiotic better be spiked like your ex's blood pressure when you text back, "K."
Whoops.
Blooper.
Okay.
It's time for a commercial break.
Yes. Let's start with Zosyn. When you don't know what's brewing, but you know it's bad.
Broad spectrum covers everything. It's the bouncer at the door of gram-positive, gram-negative, and anaerobic drama.
The side effects include stabilized blood pressure, improved perfusion, and provides nodding at you like you did something heroic.
Zosyn, given immediately after the order because sepsis waits for no one.
Next up is lupus, SLA, systemic lupus erythematosus. SLE is the autoimmune condition where the immune system wakes up and chooses violence, specifically against connective tissue. The classic symptoms are butterfly rash, photosensitivity, joint pain and swelling, fatigue, fever, mouth ulcers, Raynaud's, hair loss, and kidney involvement. That includes protein in your urine and an increased creatinine.
Organ damage is the entire plot line of SLE, and kidneys, they are the drama. Foamy urine equals proteinuria, which is time to intervene.
What are those interventions, Chelsea? Well, let me tell you. Avoid sunlight, use sunscreen, SPF of at least 30 or greater, avoid sick contacts, balance your rest and activity, manage your stress, don't be a nursing student, monitor kidneys, pain and inflammation control. The medications you want to use include nonsteroidal anti-inflammatories, steroids, immune suppressants, and hydroxychloroquine. Why can't I say that? Let's just call it Plaquenil.
And if your SLE patient is on Plaquenil and reports any vision changes, this is a call the provider right now situation. And now it's time for a commercial from our unofficial sponsor.
Plaquenil, the medication originally designed for malaria because nothing says modern medicine like using mosquito medicine to calm the immune chaos.
Yes, Plaquenil, the drug that once protected travelers from parasite-carrying mosquitoes and now prevents your joints from acting like they're in a bar fight.
Common side effects include GI upset, headache, and the dawning realization that your immune system might be the true villain.
Serious side effects include retinal toxicity, which is why those routine ophthalmology visits are not optional.
Plaquenil, turning malaria meds into immune miracles. Next up, after that fabulous commercial break, is HIV. HIV destroys CD4 cells, weakening the immune system until opportunistic infections line up like it's Black Friday. The labs you want to look at are a low CD4 and a high viral load. The goal is to suppress the viral load and CD4 recovery. The symptoms we'll see in these patients are recurrent infections, oral thrush, night sweats, lymphadenopathy, weight loss, and possible Kaposi sarcoma lesions.
Medication adherence is life. Skipping doses leads to resistance, and resistance is like deleting your antivirus during a cyber attack.
How do we teach our patients? We need to teach them that antiretroviral therapy is the same time every day. Don't skip your doses, no needle sharing, practice safe sex, report any new symptoms, and keep your follow-up visits. Lastly, manage your emotional and psychological health. This can be a life-changing diagnosis and really can be managed if we get good care.
That's right. HIV itself doesn't kill. It is those opportunistic infections that do. So treatment is everything for these patients.
Guess what, Chelsea? It's time for another unofficially postured commercial. All right, so we're talking about Biktarvy. It's a combo medication, one pill once a day, and it's a big impact.
Side effects include nausea, diarrhea, dreams so vivid you question the simulation, and the thrill of watching your viral load drop like it's on a self-care journey.
Biktarvy, treating HIV by helping the immune system glow up since launch day.
And don't skip doses. This isn't the science fair where we grow resistant HIV.
Next up, we're going to talk about cancer. Cancer begins when the cells stop following rules. There's no apoptosis, no boundaries. The core concepts with cancer cell development is uncontrolled cell growth, loss of differentiation, loss of contact inhibition, angiogenesis, and metastasis. We classify cancer using grading, meaning the aggression, how aggressive it is, staging, looking at the spread, how far the tumor has spread, and then the TNM classification system for tumor, how many nodes are involved, and if there is the presence of metastasis.
Diagnostics, we can look at some tumor markers, some imaging, CT, MRI, PET scan, but any definitive diagnosis is going to include a biopsy. Complications of cancer in general, especially associated with the treatments. So myelosuppression, myelo meaning bone marrow, neutropenia, thrombocytopenia, fatigue, alopecia, nausea, and vomiting.
As a nurse, the care that we want to focus on is infection prevention, bleeding precautions, supporting our patients emotionally, adequate nutrition, nutrition saves lives, mouth care, and monitoring their lab values, looking for those sneaky signs that something's sneaking up on us.
Yeah, and as we just talked about HIV, that Kaposi sarcoma is an opportunistic infection, but it's actually a type of cancer. So it could be that if you see that, those purple spots.
It's time again for another commercial. Let's talk about the chemo cocktail.
Side effects include nausea, alopecia, neutropenia, fatigue, and naming your last eyelashes for emotional support.
The chemo cocktail is a vesicant, meaning if it infiltrates, there's going to be tissue damage and it's going to be catastrophic.
That's why it goes through a central line or port only. Peripheral veins did not sign up for chemical warfare.
The chemo cocktail, it's potent, it's precise, and it's prepared for battle.
All right. Moving on into Unit 2, atrial dysrhythmias, rapid response teams, and code blues, where the heart throws tantrums and we fix them.
Atrial dysrhythmias. Atrial dysrhythmias are the heart's group chat at 3 a.m. They're chaotic and dramatic. So in this episode, we're covering AFib, A-flutter, SVT, supraventricular tachycardia, PACs, premature atrial contractions, and a first-degree AV block. First up is AFib. This rhythm is irregularly irregular. There are no P waves, and the QRS is narrow or within normal range. The major risk factor here is throwing a clot, and we watch out for strokes.
If it's AFib with RVR or rapid ventricular rate, we need to check our patient's perfusion. If they're stable, we can probably treat it with meds. If they're unstable, they're going to need some type of cardioversion.
Next up is atrial flutter. We also call it A flutter. This one's kind of cool when you see it on the monitor. It has those sawtooth waves that are taking the place of a P wave. They are not called P waves. They are called flutter waves or sawtooth waves. And this represents your atria firing at roughly 250 to 350 beats per minute.
Yes, the atria are flapping like little birds.
I love that. Supraventricular tachycardia, meaning it originates above the ventricle. The rate here is about 150 to 220. The QRS remains narrow, and it can be sudden onset.
Right. And so if it's stable, we might cardiovert them chemically with adenosine. If it's unstable, meaning how does your patient look? How is their perfusion? Are they still awake? Are they talking to you? Are they clammy? Do they look awful? They might need synchronized cardioversion. Warn them before they momentarily leave their body.
Yes, that would be shocking if you used some electricity on my chest and didn't tell me that I'm going to temporarily die. All right, next up is PACs, premature atrial contractions, early atrial beats.
PACs are the "you up" text of EKGs, annoying but harmless.
Yeah, don't worry about them. Just watch them. First degree AV block. This one's so fun. It's not really a block. Block is a complete misnomer, but it's medicine, so we have to stay in a state of constant confusion. This is when the PR interval is greater than 0.20 seconds. It just takes a little bit longer for that impulse to travel from the SA node down to the AV node and get through.
Yep, it's a delay in conduction. It's not dangerous. The electrical signal is basically saying, I'll reply when I feel like it.
I have friends like that.
Yeah.
All right. We kind of mentioned it a little bit earlier, but now let's talk a little bit about cardioversion. This is used when a patient is unstable, but they have a pulse. Cardioversion converts a rhythm into a normal or a regular rhythm. We use this for atrial fibrillation, atrial flutter, and SVT.
Yep, it's kind of like resetting, turning off the computer and turning it back on for the heart. So checklist, if we're doing electrical cardioversion, obviously very painful, so we're going to want to give them some type of pain medication or procedural sedation, have all of the emergency rescue equipment that goes along with doing procedural sedation, consentable procedure, we're going to want to have oxygen, bag valve mask, all of those things at the bedside. And probably the most important thing is that cardioversion has to be synced with the R wave. So every single time you have to tell the machine to sync it to the R wave so you don't send them into a fatal rhythm.
It's so cool that a computer can do that for us and we don't have to try to be so on time because I'd be late for everything.
Oh, yes. Defibrillation is chaotic. Cardioversion is polite.
We love that. Guess what time it is?
Time for a note from our unofficial sponsors, adenosine.
This commercial is not sponsored by adenosine, the drug that should sponsor us because it's kind of cool.
Adenosine, for when the heart needs a hard rest.
Give fast, flush faster, and prepare for their brief cosmic FaceTime with the universe.
Side effects include chest pressure, doom awareness, and an immediate but usually temporary return to normal rhythm.
Adenosine reveals the rhythm. It does not sustain the fix.
Adenosine, the Control-Alt-Delete of cardiology.
And yes, the chaos comes back, but now you know what you're dealing with. All right, now let's talk about Rapid Response Team, or RRT. Remember, this is our job as nurses. This is one of the greatest things that they implemented that really allow us to show we are picking up on those subtle cues. RRT is called before they code, before something disastrous happens. This is used for a patient that is now in new onset respiratory distress, if they have a sudden level of consciousness change, or if they have a new hypotension, new tachyarrhythmias, or something just feels wrong. This is when our nursing intuition is like, nope, something's bad.
Yep, our nursing intuition is everything. If your gut whispers no, just call the RRT. We're trying to prevent the code blue. And when they're code blue, they are dead or they're actively dying, and we need to bring them back.
Yes, not good. Our priorities in a code blue is get your hands on that chest. Start compressions immediately. We've got to restore some semblance of circulation. Bag mask ventilation. Defibrillate if it's indicated. Once we learn all those rhythms that we use that electricity with, defibrillate. Follow the protocols, advance cardiac life support, and switch compressors every 2 minutes.
Yeah, and so defibrillation is for when you're dead, D for dead, because there's nothing to sync it to. So that would be your pulseless VFib, your VTAC without a pulse. That's going to be a defibrillate. Remember, your synchronized cardioversion is for a patient with a pulse.
Yes, excellent. Our role as nurses is compressions, bagging the patient with the bag valve mask, medication pushes, IV access, and keeping the room functional. What I want to reinforce is bagging does not mean we want to put them in a body bag. We want to prevent that.
That's right.
All right. Let's talk a little bit about palliative care, the before the body bag conversation.
Yep.
So palliative care is really focused on care at any stage, and we want the aim is comfort. This includes things like pain relief, controlling nausea, helping them sleep. Patients need sleep, emotional and spiritual support, communicating with the family, and setting goals of care that are attainable.
Right, and we have to work in that role as the patient advocate. If you have a patient, whether they're, regardless of what department in the hospital that they are in, you can work with them to try to make things happen. I had one patient before where we actually had a wedding. His biggest regret was not marrying. So we decorated it with the isolation gowns, housekeeping bought flowers. Like we had a wedding. It was very sweet. If they want to have their fur baby come in and visit, we can try to find ways to make that happen too.
Yeah, and it's all legal boundaries. We can do that, and it's really an opportunity for us to really shine and advocate for our patients. I love that.
Yep. And it is time for another commercial break from our unofficial sponsor.
Morphine, relieving suffering since before nursing school existed.
Side effects include respiratory depression, constipation, itching, nausea, and a depth of peace that makes the patient actually rest.
Morphine, easing pain, easing breathing, easing everything.
And in palliative care, comfort isn't optional. It's the whole assignment.
All right, keeping up with our final exam review, we're moving on to Unit 3, Geriatrics, where aging is normal, but suffering is not. Caring for older clients means understanding that aging changes everything. How symptoms show up, how medications work, how the body compensates, and even how they tell you something is wrong. Older adults rarely give you classic signs, but what they do give you are subtle changes.
And they are the undefeated champions of, I'm fine. Absolutely
not fine.
It's just old age.
Nope.
Dehydration or infection. I don't want to bother anyone.
Please bother me.
Underreporting symptoms is practically a personality trait.
Delirium and an atypical presentation can also happen in geriatrics. Delirium can be the first or only sign indicating they have an infection. Maybe they have pain or dehydration or an electrolyte imbalance or hypoxia or that they have medication issues.
Right. You hear a lot of times nurses will say, especially those that work in like the skilled nursing facilities or longer term care, that, they're confused. It's just a bladder infection. It's expected. But that could also be signs of sepsis. So delirium, confusion. If grandpa starts having deep conversations with the coat rack, it's not necessarily quirky. It's a clinical change.
Subtle changes are the way that we really show what we know what we're doing. All right. Polypharmacy and medication safety in the older adults, they have slower drug metabolisms, a decreased kidney function, increased sensitivity to meds. They have more drug interactions, and they have a higher fall risk.
So translation, start low, go slow, and question every medication like it's a suspicious text from an unknown number.
And never answer those.
No.
A sudden decline in mobility or in our patient's appetite or participation is a huge red flag. Once again, a subtle sign.
Mm-hmm. And if someone says they don't need physical therapy, somewhere a physical therapist just threw their clipboard.
It's time again for a geriatric commercial break. Your friend and mine, Miralax. Miralax, because sometimes nature needs a nudge.
Side effects include gentle relief, a little more pep in their step, and a bowel movement so polite it practically says, thank you.
Miralax. Mix it, sip it, wait for it. Comfort is on the way.
Because in geriatrics, a good poop can change the entire trajectory of the day.
And in midlife, too. I'm not going to lie.
Miralax.
All right, moving on. Unit 4, musculoskeletal, where bones break rules, nerves misbehave, and structure loses the battle with stress. We're going to start off with bone tumors and metastatic bone disease. Bone tumors, whether they are primary or metastatic, they destroy normal bone and spill everything inside the bone matrix into the bloodstream. And that means one very testable thing: calcium and phosphorus.
Osteolysis releases both minerals. So in bone cancer, you expect high calcium and high phosphorus, whereas they normally have an inverse relationship. Not in this case. The high combo is a classic clue that the cancer is in the bone.
So this is going to result in hypercalcemia. High calcium slows down nearly every system. So what we see are patients with constipation, fatigue, weakness, confusion, slowed reflexes, dysrhythmias, and their GI is going to slow down. Calcium turns the body into molasses mode.
That always reminds me of the Jimmy Buffett and Alan Jackson. It's like molasses in wintertime.
Oh,
yeah.
yeah, love it.
So quick tie-in about calcium gluconate. We can take that back to hyperkalemia. So because that's another way you can remember it, how calcium slows everything down. Well, it also stabilizes that cardiac membrane, slowing down the chaos. So sometimes if your patient's hyperkalemic, we'll give them calcium gluconate to serve as a Band-Aid, stabilize that cardiac membrane, and buy us some time while we fix those potassiums. Phosphorus is also high in bone tumors.
Yeah, because the bone stores calcium and phosphate, tumor destruction releases both. So high calcium plus high phosphate. Usually that relationship is inverted when one is high and the other is low, but in this case, we have both elevated. This means there's strong evidence that the cancer is inside the bone.
We've said that twice. It must be important.
Oh, I wonder if they're going to see it again. So what happens because we have this loss of calcium is we get something called pathological fractures. Bone tumors replace the strong bone with weakened, brittle, abnormal tissue, and this creates fragile areas that can break under minimal force. Pathological fractures can happen during normal daily activity, occur in weakened bones, not due to trauma. They present as a sudden, sharp, localized pain, and they're common in the femur, in the pelvis, the ribs, and the vertebrae.
If a patient says, "I just turned in bed and something cracked," that is never a normal sentence, and you should take it seriously. This is pathological fracture energy.
And these fractures are true emergencies because the bone is so unstable and the risk of more fractures is high.
Right. Let's move into our other topic, amputations. Amputation could be necessary for a number of varying factors, but how do we take care of that post-op patient?
Well, after an amputation, we focus on preventing complications and maximizing long-term function. So the key concepts here are prone positioning on post-op day 2 to 3. The reason we place a patient prone is to prevent hip flexion, and that can lead to contractures. So we don't want those hip flexion contractures to happen. So we can apply compression dressings or stump shrinkers. We want to monitor their circulation, make sure that the remaining stump has good circulation so it can heal, assess for bleeding, prevent infection, and manage phantom limb sensations.
Right. Do the patients want to be proned? Not really. Never. Do you make them do it anyways? Yeah, because future mobility is the whole assignment.
Yeah, we got to be thinking long term. What could happen as a complication of this?
And educate our patients for the reason behind those interventions.
And it's not just because I'm mad at you.
Right.
I want you prone.
Right. Yeah.
All right.
And then we have the phantom limb pain. If your patient's complaining of pain in the area where the limb used to be, that's considered phantom limb pain. It's like a ghost. That's how I remembered it. But then you can also develop something called a neuroma.
Yeah, neuroma pain. That sounds horrible. It's a sharp, burning, electric shock-like pain in the stump. That's a neuroma. It's a tangled ball of overactive nerve tissue.
Right. So basically the nerves tie themselves into an angry little fist and begin throwing hands.
Yeah. You treat it with steroid injections, local anesthetics, nerve pain meds, and surgical removal if it's severe. That kind of acts like the referee in this fight.
And don't just label this normal healing pain. If your patient's maybe prosthesis is causing them discomfort and the pain is in the stump, think neuroma.
Yeah, neuroma pain, it's in its own category.
And it looks like it's time for another commercial break from one of our not paid sponsors.
Feel free to pay us.
Feel
We're
free.
happy to take your cash.
Coffee cup.
Yeah, Venmo. All right. Our next medication is oxycodone for pain that's bad, but not Dilaudid bad.
Side effects include nausea, sedation, constipation, and thinking your nurse ghosted you when they're literally just down the hall.
Oxycodone. It's strong enough for post-op amputation or tumor-related bone pain, but gentle enough that you can still have a conversation afterward.
Relief that lets you move in bed without screaming. That's what we call progress. Oxycodone.
We love it. All right, moving on to Unit 5, Fluids and Electrolytes, where the human body proves it's mostly water and somehow still dramatic. Let's start off talking about crystalloids. Crystalloids are your everyday fluids. They start in the vessels, then redistribute because their particles are small enough to move across compartments. And it's so important to know what each crystalloid does. Picking the wrong one can crash a sodium, worsen intracranial pressure, or turn dehydration into edema.
Each one has a personality. Your job, fluid matchmaking.
So let's talk about some common examples and what they do. So first off is normal saline, 0.9%. This stays intravascular initially. It restores volume, and it's used for dehydration, hypovolemia, and shock. Then we have lactated ringers, or LR. This is the most physiologic. It's great for trauma. It's great for burns, and it's great for pancreatitis. It's used when you need to balance electrolytes. This one also turns to lactate by the liver, so can help correct some acidosis.
Right, and so those were both isotonic, and now we've got some hypotonics. So those dextrose-containing fluids, this is perhaps the most confusing thing for nursing students, is when it's on the shelf, the tonicity is actually a level higher than it is when it's in the body. So D5W, as soon as we start infusing that dextrose burns off pretty much right away, and what you're actually just giving them is plain old water. So isotonic on the shelf, hypotonic in the body, and that's what we as nurses need to know, what it does in the body. So this is used for cellular dehydration, never for a patient with a neurological injury at risk for increased intracranial pressure and cerebral edema.
Yeah, that's not good.
Yep. Another common hypotonic is your half normal, 0.45% NS, gentle free water replacement. Could be used for hypernatremia, severe dehydration perhaps.
So crystalloids show up fast and hydrate the tissues. They're just not the best at staying where you put them.
Unless they're an isotonic.
Yeah, then they're
pretty good.
Yeah.
That's why we use isotonic for sepsis.
Yes, we love
30
sepsis.
mils per kick.
Yes.
All right. Let's talk about colloids.
Colloids, they stay in the bloodstream and pull fluid in with them. A great one I love to use. I use this all the time when I'm working in radiology after some of our procedures. Albumin. Albumin expands the plasma volume. It pulls third space fluid back into circulation. It's used in ascites, liver failure, and hypoalbuminemia. One note about albumin is don't look like a brand new nurse. Let's fake it till we make it. Here's my helpful tip for you. If your patient is getting both Lasix and albumin because they are swollen like the Michelin Man, you need to make sure that you give that albumin, let it pull the fluid out, and then wait. Give your Lasix after about 30 to 45 minutes. You're welcome.
You would be amazed how many experienced nurses don't understand that concept. Unless your patient is like drowning in their own lungs right in front of you, like if you're really trying to help just diurese them adequately, we're going to give that albumin first.
Yeah, and you know, Chelsea, the reason that they don't know that is because they never listen to our podcast.
That's true.
That's the reason. I mean, we're saving lives over here.
That's right.
Yeah.
Yeah, blood products too. Also, you know, they're a colloid. Your blood products are, and any of these, the blood products also, they can really add a lot of circulatory overload. So we wouldn't want to be giving any of those other fluids simultaneously with the blood. And sometimes patients even need diuresis after a lot of replacement.
Yeah, that can sneak up on our blood products that we look at are packed red blood cells, fresh frozen plasma or FFP, and platelets. These restore oxygen carrying capacity. They restore clotting factors or platelets, and they are true volume replacements. This is going into your intravascular volume right here.
Right. So if crystalloids are water balloons, colloids are weighted blankets, heavier, pricier, and they stay exactly where you put them. And then let's move on to some parenteral nutrition. So we've got two types, PPN and TPN. So PPN is peripheral parenteral nutrition. It has a little bit of a much lower osmolality than your TPN, which is why it's okay to give peripheral nutrition through a peripheral line. It's a short-term supplemental aid. It's not for full nutritional support. Think of it like a snack.
Yeah, then we have total parenteral nutrition, or TPN. This has a high osmolarity. It must go through a central line. It's complete nutrition. It has your amino acids that act as your proteins. It's got your fats, and it's got your carbohydrates. It's customized daily based on the patient's lab. It's very patient specific. The problem is that there's a high incidence for infection and hyperglycemia risk because there's a lot of dextrose in there. So when we stop the TPN suddenly, if the night shift nurse forgot to order the bag, or the day shift nurse, actually, it would be a day shift nurse problem because the day shift nurse needs to order it. We hang it usually at night.
You know what? That's true.
Yeah,
it would be a day shift problem.
So when the day shift traveler forgets to order your TPN.
Hey, nothing wrong with the travelers.
No, love me some travelers. So when the day shift traveler stops to order.
I think we should blame it on the pharmacy.
Oh, yeah, okay. Yeah. Pharmacy. Yep. When pharmacy doesn't send your TPN and it suddenly stops, your glucose is going to crash hard. So our TPN patient is going to become difficult to arouse. We have to assume they're hypoglycemic first.
So what do? You just go hang D10. It's not like, let me call the provider and wait for a return phone call. If your TPN is running dry and you're still waiting on it from the pharmacy, then you just hang D10, and then, you got to think about your patient's brain, right? So you hang D10, check their sugar, and then you call the provider and you let them know, especially, if it's going to be a while, like, hey, pharmacy's just not getting me my TPN tonight. They might give you some further orders or have you wean that dextrose down throughout the night. But first action, hang D10.
Yep. Brain first, phone call second.
That's right.
All right. Next, let's talk about hyperkalemia. Hyperkalemia management is in 3 categories. If you memorize these, you understand all of it. First, we want to stabilize the cardiac membrane, prevent dysrhythmias, and this is where we administer calcium gluconate. Second, we shift potassium intracellularly. So we want to temporarily lower the serum potassium, and this is by giving insulin plus dextrose, and we can also use albuterol breathing treatments for this.
And sodium bicarb as well, right?
Correct.
Yep.
Yes.
So insulin with the dextrose so we don't tank them, albuterol, that one always throws me off, and sodium bicarb all will help shift it from, shift the potassium intracellularly. And then we can also remove total body content, just get it out of the body. So we could do this with dialysis or GI binders like K-oxalate.
Yeah.
And they poop it out.
Yeah, that was our third step of it, removing that potassium from the body. A little extra credit tip for you. We live in a very poor air quality area, and we see a lot of patients with respiratory diseases, whether it would be COPD, asthma exacerbation, allergic reactions. So we give a lot of albuterol treatments, and as a nurse, we really have to start watching for hypokalemia because those serial breathing treatments can drop that potassium, and we can subtly miss that.
I actually don't think that I knew that about the albuterol until a few years ago. Like I hadn't known that. That was not something that was in my nursing education.
Yeah.
Was it in yours? I didn't remember. Yeah.
Now, listen to the
albuterol.
podcast.
Mm-hmm.
Yep.
Yeah.
Another tip from the podcast.
And let's have a brief commercial break.
Regular insulin. The only insulin classy enough for IV push.
Side effects include potassium diving into the cells, blood sugar politely stepping down, and you feel like you're directing molecular traffic with absolute authority.
It doesn't negotiate with potassium. It just picks it up, walks inside the cell, and locks the door.
Fast, effective, and the star of every hyperkalemia emergency. Regular insulin.
Oh, this is a fun one. Acid
This
base.
is one of my favorites.
Here we go. We're going to do this a little bit Laura Gaspara style.
That's right.
If you haven't listened to her video on this, you really should Google it.
I show mine in class.
Yeah.
Laura Gaspara, she does the education. It's on YouTube. She's a great resource like for studying for, CCRN later on if you go get certification in critical care. But she's got this one YouTube video on ABGs that she's all about sharing with nursing students. So this is where ABGs become a family drama.
So, step 1, start with the pH. Always, 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 always start with the pH. And your dividing line is 7.40. Think perfect, like Dave Harding, 7.40. The pH that's less than 7.40 is acidic. The pH that is greater than 7.40 is more basic or alkalotic.
The pH is the vibe check of the whole situation. If the vibe is off, everything downstream is chaos.
So then the next step, I'm sorry, Chels.
Oh, we're just so excited about ABGs.
I know.
Who matches the pH? The problem. The one that matches the pH is the problem, or the baby daddy, if we're talking about it as an ABG baby.
I love it. Yeah, so we have our two players, the CO2, which is respiratory, and the bicarb, which is metabolic.
So ask yourself, which one matches the pH? That's the problem. That's the father.
So if it's an acidic pH, we have to ask who else is acidic. And if it's a basic pH, we have to ask who else is basic. Whoever matches the pH is the cause. That's the father of this ABG baby and the source of all the drama.
You don't even have to like him. You just have to identify him. Step 3, who's trying to fix it? This is the new man in your life. Look at the value that does not match the pH.
If the other value is abnormal, that means the organ system is trying to compensate, aka the new man is trying to clean up the disaster.
If the pH is still normal, he hasn't shown up yet. You're still alone with the baby daddy.
Actually, the pH could be normal. It would be the opposite value.
If it's normal, wait, let me think about this for a second. The value that does not, that's right.
Yeah, the other value. These can be confusing.
Good catch.
Yes. Yeah.
Yes.
Yeah. So if it's normal, if that opposite value, so we've matched our pH with
Right.
our whatever value that matches our pH. And then if the other value is normal, then it hasn't shown up yet. So you're still alone with the baby daddy.
Right.
Yeah.
Yep. So the last step really is kind of where we were just going here. So deciding your compensation status. So if you're fully compensated, the pH is normal, okay, but your CO2 and your bicarb are not normal. So
Yeah, that means our new man fixed it. Balance is restored and peace has been returned. So we're getting them back within the normal range. The pH is within 7.35 and 7.45, but the CO2 and bicarb are both abnormal. One's causing the problem and the other one is fixing the problem.
right, whereas you can actually have partially compensated where the pH is abnormal and both of the other values are abnormal. That's the key for nursing students, is that all 3 values are abnormal. So
Yeah.
still in partially compensated, the one that matches the pH is the problem. The other abnormal value, but that doesn't match the pH as an acid or base, is the one that's trying to fix the problem.
Yeah, so everyone's trying, but the relationship is still in chaos.
Yes, this is group project energy. Baby daddy caused the mess. New man is working on it. pH still looks like a crime scene.
Then we have the uncompensated, where the pH is abnormal, but only one of the other values is abnormal. This is the easiest one to identify because the other value, of the 3 values, the pH,
Right.
the CO2, and bicarb, the pH is abnormal, and only one, the pH or the bicarb, is abnormal, and then the last one is normal. Nobody's helping. No one.
You're alone on the dating apps, swiping, refreshing, losing hope.
Okay, so where are you at today, Chelsea? Are you fully compensated, partial compensated, or still out there uncompensated in the online dating pool?
Ooh, I am somewhere in between partial and uncompensated. My pH is not vibing.
And that is how you read ABGs. All right, it is time for another commercial. Our favorite, sodium bicarb. Sodium bicarb is the drug that shows up when things have gotten real acidic.
Side effects include pH rising from the dead, CO2 climbing like it's training for Everest, and nurses everywhere whispering, "We only use this when we have to."
Sodium bicarb is not your first date, not your first choice, and definitely not your first line treatment.
But when the pH drops so low it's texting the underworld, when your metabolic acidosis is giving end of days energy, that's when sodium bicarb kicks the door open like, all right, who messed up the acid-base balance?
It buffers hydrogen ions, buys time, and gives the body one last pep talk while you fix the real issue.
Because sometimes the pH needs a little nudge and a lot of drama.
Sodium bicarb, for when all other boundaries have been crossed. Okay, welcome back to the Just Hard podcast. We're moving on to Unit 6, renal, end-stage renal disease and GU cancers as our final review, where the kidneys quit their job, dialysis becomes the new boss, and urine is never subtle. CKD and end-stage renal disease are the kidneys slowly sending resignation emails and then one day switching on an out-of-office message for the entire body. So what actually happens when our kidneys stop working, we go into end-stage renal disease, our potassium is going to rise, our phosphorus is going to rise, our calcium is going to fall, bicarb is going to drop, and so we're going to have a patient that has metabolic acidosis. Our red blood cells are going to drop. We're going to have patients that are showing signs of anemia. Fluid overload, they're going to become hypertensive, and then they're going to have uremic symptoms. They're going to be itching, have a metallic taste in their mouth, maybe complain of some nausea, and maybe even get confused.
When the kidneys retire, every electrolyte pulls a full reality TV meltdown. And then these patients, if they have to go on dialysis is a huge lifestyle change for them.
Yeah, dialysis isn't just a treatment. It's literally an identity shift. The fatigue, the schedule, the food restrictions, it's a whole emotional and physical adjustment.
Yeah, I think the food restrictions are probably the worst. That renal diet is so strict.
Boring.
When you're on dialysis, it's like, how much water can I have? What is my blood pressure today? When am I going to dialysis? Why am I so tired? And
it's hard.
It's hard. Yep. Patients need support, empathy, and realistic expectations. And these patients are very fragile. They will code on you in any minute. If you think about it, they're just walking around with an organ failed all the time.
Sister,
yeah.
I was in talking to the dialysis nurse because I'm super social, and the patient was there too, but they were getting dialysis, but I was just doing some social stuff, and the patient began to be part of our conversation. I think we were talking about a television show, and all of a sudden I look over, patient dead.
Yep.
Dead.
Yep. And you got to watch those dialysis nurses too. Some of them are absolutely phenomenal.
Yep.
But just like with everything, right? Like some, you really got to watch them because some of them will come in with this idea like, oh, I have to pull 2 liters. And they're going to pull 2 liters even if their blood pressure is tanking. So sometimes you got to be like, hey, I need you to back off a little bit.
My patient looks like a raisin.
Yeah.
Could we stop?
Yeah. Return the blood. Back off.
Yeah.
Call to the doctor. But those patients are very unstable, and not only during their dialysis treatment. They're walking around in organ failure. They can code on you anytime.
Yeah, we were full on having a conversation. I literally thought the patient just paused to put her thoughts together. And when I looked at her, dead. Yeah.
Yep.
RRT.
Yep.
Yeah. But
code blue.
Yeah. It was not an RRT moment. It was a code blue moment.
Yeah.
But in my
crazy,
defense,
though,
she didn't give me any cues.
Yeah. No, they don't always, right?
Sneaky little thing.
But it's crazy how you can tell, like, just by looking at them, sometimes without even doing your pulse check,
Yeah.
You're
Dead.
Like,
Dead.
Yep.
We were there.
Yep.
All right. So with a dialysis patient, there is one rule that never changes. We have to protect that fistula arm like it's Beyonce. There is no blood pressure checks on the arm with the fistula, no blood draws on the arm with the fistula, no tight sleeves on the arm with a fistula, no trauma to the arm with a fistula. If the patient has a bruit or a thrill and it disappears, that's a dialysis emergency. In that case, we got to prepare for a VAS cath or an ASH cath because that patient still needs dialysis.
That's right. So another invasive line, and sometimes it's so hard to get any type of access on these patients too. Quick review on the fistula patency. How do you know if your fistula is patent?
Ooh, we got to feel the thrill, but hear the bruit.
That's right. So if you lose patency, if you don't feel a thrill or you don't hear the bruit, that is Beyonce level drama. Call nephrology immediately. They need a new temporary access.
That's when you get to call your fabulous interventional radiology team.
Woohoo!
Let's give them a shout out. Yeah. And if it gets really bad, then we're going to call our favorite ICU nurse.
Yes.
Yes.
Yep. GU cancers. Cancers of the genitourinary system. Let's do a final review. We're going to boil this down to a couple of themes that you must know. With any of the cancers of the like bladder cancer, renal cancer, all those things, hematuria and smoking. Those are the 2 things you really got to look out for. Smoking is a major risk factor, and hematuria is that red flag.
Yeah, it's kind of not as intuitive as like lung cancer would be with smoking, right? Yeah,
right.
It's not as intuitive. Yeah. In this case, if we have hematuria, it's a red flag. If the urine looks like a rosé and nobody's celebrating, think GU cancer.
Renal cell carcinoma, you might see hematuria, flank pain, a mass, weight loss, polycythemia, and it can be silent until it's discovered later on. And then if those patients have to have like any type of surgical intervention too, sometimes they lose the entire kidney, sometimes they lose the adrenal gland. I had one patient who had a total nephrectomy on one side for cancer, and then she had a partial on the other side with adrenal gland, part of the adrenal gland removed. And she was super unstable and had to take the hydrocortisone and everything. And I think that maybe what had happened, because I had her post cardiac arrest in the unit, and her blood pressure had shot up to the major 200s, and she had a bleed. And I've always wondered if it had something to do with those adrenal glands that got involved in that.
Yeah, we often overlook those. Yeah, because the kidney is just such the prima donna of the body.
Oh, yes, for sure.
Yeah. Yeah, I think with renal cell carcinoma too, we get the cancers and they cause the increased hormone production. So we get increased erythropoietin, and that's why these patients get that polycythemia. Yeah.
Kind of the opposite for your patient whose kidney has failed and they don't have enough of the epithelium.
Correct. Yeah, because remember with cancer, you got that increased cell growth. And so even the hormones are even overactive.
Cancer tumors just do their own thing.
Yeah. Speaking of cancer, bladder cancer. The signs we see on this: painless hematuria. Smoking is the number one risk factor, and we diagnose this by cystoscopy.
Prostate cancer, weak stream, hesitancy, nocturia, hematuria. Back and pelvic pain would actually be a late sign. Prostate cancer is very treatable if it's caught early. And if a man's pee stream looks sad and confused, prostate cancer is on the list.
Definitely. Yeah, then we can move on to testicular cancer. In this one, the patients might feel a painless lump. They might feel a heavy feeling to the scrotum, swelling. This happens to patients ages 15 to 35. Early detection here, we have an excellent cure rate. If the patient finds something weird down there, we don't watch, we scan.
Right. The key here is early detection, because if we don't catch it early and it's metastasized, it's not good. Let's have another commercial break from one of our not official sponsors.
All right. Speaking of renal, let's talk about phosphate binders, because phosphorus in end-stage renal disease has been out here acting unhinged.
Side effects include happier bones, less itching, and ESRD patients asking for the millionth time, do I really have to take it with food? Yes, with food, always, every meal, forever.
Phosphate binders tackle phosphorus in the gut like a linebacker taking down a streaker at the Super Bowl.
Phosphate binders, protecting calcium's peace and sanity religiously.
Give it with food. Another commercial for Epogen. Epogen, because when chronic kidney disease takes your erythropoietin, your energy levels shouldn't have to retire too.
With Epogen, patients may experience hemoglobin rising from absolutely unacceptable to socially appropriate, a mild but meaningful return of stamina, and moments of clarity where they wonder, am I actually less tired, or am I just tired with dignity?
Epogen works by encouraging your bone marrow to produce red blood cells again, gently reminding it, hey friend, we know you're exhausted, but the body still needs you.
In clinical practice, Epogen helps transform energy from barely surviving into, okay, I guess I can get up now.
Ask your provider if Epogen is right for you, because even in ESRD, your hemoglobin deserves a second chance.
Epogen, helping patients go from tragic to fatigue to functional-ish since forever.
All right. Unit 7, oxygenation, chest trauma, and chest tubes. Where oxygen delivery climbs the ladder, lungs get dramatic, and chest tubes save reputations. So let's talk about some oxygen delivery devices. Oxygen devices are a staircase. You don't jump around, you climb it based on how bad things are going.
Yeah, so a nasal cannula gives 1 to 6 liters per minute. It's a low-flow device. Patient can eat and talk. Good for mild, stable hypoxia.
This is your gentle, cooperative bestie. Unlike a simple face mask, we can use that with 6 to 12 liters per minute. It must be greater than 6 liters to clear off that CO2. And this is for a patient that has moderate oxygen needs.
And my favorite is the non-rebreather. That's my go-to in a rapid response, right? That's your rescue. It gives nearly 100% FiO2. The key thing here, and you'll see a lot of nurses miss it, so don't be afraid to step up if you notice that that reservoir bag is not inflated. That reservoir bag has to be inflated, or else the patient's kind of essentially suffocating in a way. So you've got to turn up that dial on that flow meter all the way up. Short-term rescue device, hopefully we can turn them around before considering an advanced airway.
Another super cool mask device is a Venturi mask. This delivers the most precise FiO2. This is ideal for COPD patients where we don't want to hyperoxygenate them. When you need accuracy, not vibes, this is the mask for you.
And then we have the high flow nasal cannula. You might see some of the brand names Vapotherm, OptiFlow. We use this a lot. We used it a lot during COVID. We had patients that were prone on a non-rebreather and a high flow, trying to prevent them from having to require intubation. Not ideal, totally different times. And you are going to see some of these patients on the floors. Now, the patients are sicker and sicker if they're in the hospital. They're sicker on those med-surg tele floors. What used to be probably a step down is now your tele unit.
Yeah.
So high flow up to 60 liters per minute. So you're going to want to report off on how many liters per minute and the FiO2 being delivered. Heated and humidified. Really, anytime we're giving more than, 4 liters, I would say they need to be humidified. Helps reduce work of breathing. It actually even gives them a little bit of PEEP.
Yeah. Great bridge between before we use BiPAP or have to intubate the patient. Speaking of BiPAP and CPAP. Positive pressure ventilation without intubation. This patient must have an intact respiratory drive. It can be very weak, but they must be able to initiate a breath and be able to exhale a little bit.
That's right. They can be, BiPAP can be very, very dangerous if you put it on the patient that really doesn't meet the correct criteria. If they have excessive secretions, that positive pressure is just going to push those secretions down and they're going to be aspirating them. Altered level of consciousness or any type of profound weakness where they cannot take that mask off themselves, because if they vomit and they can't take that mask off, not good. That positive pressure is just putting all that vomit into the lungs. So if your patient, never restrain them on BiPAP. If like in those rare situations, they're usually going to be in the ICU with a 1-to-1 line of sight safety sitter to take that mask off for them if needed.
Yeah, we would also never use it on anyone with facial trauma or anyone that is a post-laryngectomy patient because the pressures are too much.
And that's key, right? Like people forget sometimes with the laryngectomy, they're not that common. I think I've only had a couple patients with them.
Correct. Same.
So that is their only airway. That stoma is their only airway. So you can put that BiPAP on their mask and you're not doing anything but putting the air into their stomach.
Yeah, not helpful.
Nope.
Yeah. And like you mentioned, absolutely no restraints in the BiPAP patient. If they vomit with a sealed mask on, they're going to aspirate. They must be able to remove that mask.
Yep. If the doctor tells you to do it, you say absolutely not, or you have to escalate it up your chain of command, or make sure that they get a 1-to-1 sitter. And sometimes if they're that bad, they really probably need to be intubated. BiPAP is not good for rescue, really. I hate using it as a rescue. Sometimes these patients just need to be intubated. You can't live on BiPAP for 3 days straight.
Correct. Yeah. This might be a good one for maybe a palliative care patient or maybe a lung cancer hospice patient that gets a pneumonia. Maybe this might help buy them a little bit of time while they heal from the infection. But yeah.
Absolutely. We just got to be able to take it off to do that oral care every couple hours. It's so drying and so uncomfortable. Most patients really hate wearing it. Some of them have some relief, but they usually hate wearing it.
Yeah, they sure do. Yeah. And then if BiPAP doesn't work and the patient is really hypoxic or really struggling, then obviously the last step is intubation. And so this would be used when your oxygenation and ventilation is failing, when the airway can't be protected, and when nothing else that we try is working.
Right. So if the vibe is they're dying, the move is intubation.
Yeah. Moving on to chest trauma. Chest trauma always comes back to 2 things, airway and oxygenation.
If air, blood, or fluid enters the pleural space, the lung collapses like it's throwing a tantrum. You need to catch it fast.
Chest tubes exist for one purpose, to clear out what doesn't belong so the lung can re-expand. Air, blood, fluid, it doesn't matter. Negative pressure must be restored to that pleural space.
Yeah, and unless you work at a trauma center or survived working the pandemic, you probably haven't worked with a whole lot of chest tubes.
Yeah.
So we're just going to give you some brief tidbits for caring for that chest tube. So the water seal chamber, that's your number one clue. That's your window into the pleural space. You might see tidling, which is normal. That means the system is open and responding to pleural pressure changes. That's where that little white ball goes up and down. And if you have tidling and then all of a sudden you don't, you need to ask yourself, is my tube clogged or is the lung actually just resealing itself?
Yeah, use the patient's context to decide which. Is the patient getting better or is there a problem with it?
Right.
We also want to look at that, speaking of the water seal, bubbling. So we expect bubbling to be present if we have a pneumothorax. As air leaves that pleural space because there's a little hole in the lung, then we expect to see some bubbling in that water seal. That means air is escaping. As the lung heals, bubbling will decrease.
Right. The bubbling occurs from right to left, and that little water seal chamber actually has numbers on there, 1 through 5, where you can kind of use that as a guide to measure if they're improving or not.
Yeah, we do not expect bubbling if we expect fluid in that pleural space. So if there's a hemothorax or a hydrothorax, there's no air in the pleural space, so we do not anticipate bubbling.
Right. If it sounds like a spring break jacuzzi, that's bad. If it's common just collecting fluid, that's perfectly fine.
So let's talk a little bit about suction with our chest tube system. There's two main kinds, a dry suction versus wet suction. This is not to be confused with the water seal. Every Pleurovac needs a water seal. But dry suction is really set on the device. This is the suction limit that's set on the device. We just hook it up to wall suction. Wall suction is on or off. And the suction chamber in the dry seal chamber, we see a bellow that expands, and that lets us know that it's functioning. Wet suction, we see gentle bubbling. This means that it's working. But if it's a loud, chaotic bubbling, then we need to turn that down.
Yeah, I feel like I've really only seen wet suction in more of those trauma patients. It can, I think they say that it can be a little bit more,
Yeah, it's kind of dangerous because as it's bubbling, that water evaporates, and it's that water level that helps us to set the suction. So I really don't see it used much anymore.
I haven't seen it for a long time.
When Florence Nightingale and I were nursing students together, we used it, but I haven't really seen it since.
Most of what you're going to see is the dry suction. And remember that suction is controlled by the dial on the chest tube. It doesn't matter what you turn the wall suction up to as long as you turn the wall suction up high enough to inflate the bellow.
Okay, story time. Yes. So we had a group of doctors that were hired to work as nurses in our emergency room, I want to say 25 years ago. And they were not able to come and practice medicine in the United States. They were from another country. And so they were able to work as nurses because they challenged the nursing boards. And it was way back in the day when the nursing shortage was really early on. And anyway, so we had this doctor that was a nurse. He was working as a nurse. But he was trained as a physician in his country, and he was working. And the patient needed a chest tube. And so the emergency physician placed the chest tube and left the nurse to connect the Pleurovac. And the nurse did not use a Pleurovac, but set the suction directly to wall suction, bypassing the Pleurovac.
Oh,
Fortunately,
no.
It was right at shift change, and I came in to take over care, and they had just finished the procedure. And I noticed it, and I was like, what in the foreign country nursing is this? And I about panicked and realized had that suction come disconnected, all the atmospheric air would have driven right back up that tubing and gone into that pleural space and caused a massive pneumothorax.
And the trauma to the lung.
Yeah. Yeah, it was quite chaotic. I think I'm still scarred from that. And it was like 15 years ago.
And, so if you, we saw everybody had chest tubes during COVID. They all did, right? But, if you're in a situation where you don't see them that often, just ask your friends, ask your coworkers, how do I set this up? I haven't done this for a while. I don't remember. Yes. And sometimes every hospital, I learned that from when I was a traveler, every hospital, their equipment might be a little bit different, pretty much the same concepts.
Correct.
But sometimes it's a little bit different. So just ask.
Same concepts, different brands, but you're right. And I think this kind of goes back to teamwork, right? You have to be a good teammate to be a good team. Mm-hmm. Everyone needs to be a good teammate. So I need to be approachable, and I want my colleagues to be approachable. And we should never practice in silos. There's tons of stuff that I don't know that I'd love to go to my colleagues and ask, and I want to be that resource for my colleagues. So, yeah, if you would have just asked.
Right? Yeah. Good thing you came on. I feel like that happens a lot. You're going to see in healthcare so many nurses that are just downright scary.
Yeah.
And it takes one good nurse coming in and kind of fixing it. So what we do, we really do save lives, and sometimes it's not just from the medical issue that brought them into the hospital.
Yeah, that's true.
Poor care.
We're protecting them from our peers. Mm-hmm. Yes.
Back to the chest tube, the collection chamber, just the basics. So the collection chamber, the drainage canister, you trend the amount. You actually mark the levels on it with your actual Sharpie. If you have a sudden stop in the drainage, you need to be wondering if there's obstruction or, maybe is it healing, whatever was going on. And then if the chamber is full or gets knocked over, you just you have to replace the whole system because you can't measure it properly because it will spill over. So you just replace the whole system.
Yeah, in that collection chamber, we're not analyzing the fluid like a wine tasting. We're just watching the trends.
That's right. And you always want to know anytime you have a tube or drain, how much fluid did it put out for your shift so far? How much did it put out the night before, and what was the 24-hour total? Every pulmonologist for a patient with a chest tube will ask you that, and any surgeon for a patient with a drain. Those are the numbers they want to know.
Yeah, these I don't know, new, the ones that we've used, I've used my whole career, the Pleurovac. You definitely know that a nurse was involved in the creation of that because that front surface of that is fully writable. You can write on it with a pencil or a pen or a Sharpie. You don't have to get some special device to write on it. So a nurse did that because if we left it up to a non-nurse, they would have had some hieroglyphic something that we had to chart on that. Yeah.
And that's one of the only times you actually get to clamp the chest tube without an order. So sometimes the doctors will give you an order to clamp it and then they'll get an x-ray like several hours later to see if the problem is, if the pneumothorax or hemothorax is resolving. But if you have to change out that canister, you just clamp that tubing briefly, change out the drainage system, and then unclamp it. Just don't forget to unclamp it.
Yes. So congratulations if you clamp it. You just created a tension pneumothorax. Don't do it.
And if the tube comes out, we're going to treat it like an open pneumothorax or a sucking chest wound. So we need to cover it with a sterile occlusive dressing and tape it on 3 sides. So any patient with a chest tube, you should have clamps at the bedside and you should have that Vaseline gauze or the Xeroform dressing. And sometimes when we put that occlusive dressing on, even though we tape it on 3 sides, to let some of the air escape that got sucked in. But sometimes that occlusive dressing works too well.
Yes.
And it's too occlusive, and you have to lift up one side to let a little bit of that air out. And then, of course, we're going to call the provider and prepare for a new chest tube. And I know, if I accidentally pulled out a chest tube and I called the provider, I'm totally blaming it on a nursing student.
Oh, yeah. You know what I do? I blame it on respiratory. Oh. I used to blame it on X-ray until I began working with X-ray, and now they're my peers because they come rolling in with that big portable chest machine and they knock your thing up. Yeah. I used to always blame it on
I had one nurse that I was orienting, and we turned the patient in bed, and she didn't look at the tube, and she turned him, and the tube came out, and we blamed it on the orientee.
Yeah.
So you got to pay attention to your lines, drains. That tube should be hanging from the bed frame, not the rails, and not just sitting you don't really just want sitting on the floor, even though it has a kickstand. I usually use the kickstand and I hang it from the bed frame.
Yeah, because the rails go up and down.
Yep.
So that's going to change the level of your chest tube for sure.
And then you might see some subcutaneous emphysema. That feels like Rice Krispies under the skin. Snap, crackle, pop. Really nothing to do about it. It is an abnormal finding, so the provider needs to be notified. But there's probably no intervention unless it's circumferential and they needed to do something to relieve that pressure. But it's just air wandering around under the tissue.
Yeah, another word for that is crepitus, not to be confused with the other term for crepitus, which is bone on bone. Mm-hmm. But yeah, it's totally benign. It's only if it's getting worse. If you see subcutaneous air worsening, then you might have air trapped under the skin from, I remember one time we had a patient that had a tear in the trachea. So we saw some sub-Q emphysema, some crepitus around there. That was really scary.
Yeah, and we were talking about this too, the chest tubes in light of chest trauma, so like pneumothorax, hemothorax, but we also mentioned hydrothorax. So some of the things that could cause the hydrothorax in our patient, the only time I've ever really seen it, it's malignant.
Yeah, that's where we get all that fluid stuck in the pleural space for sure. Yeah. So that was when your patient gets disconnected from the patient, the chest tube. But if the tubing gets disconnected and you can't fix it immediately, place that tube end in sterile water. So you want to stick the patient's side of the tube into sterile water, and that's going to give us a temporary water seal. So always, always, always have a small container of sterile water available just in case. I'd rather have it there and waste it than not have it and my patient get disconnected and then I have another pneumothorax. So when in doubt, you want to ask yourself, do we still have a water seal?
Right. So important. And then let's talk a little bit more about the patient who has laryngeal cancer, perhaps, and has undergone a laryngectomy. What are some pre-op and post-op interventions for them?
Yeah, what we want to do is establish a communication method pre-op. So we want to use a tablet, a writing board, gestures. Sometimes our older patients that might have a little difficulty moving, like with Parkinsonian tremors or something, can't use a tablet to touch things. So we might have a board with pictures or images that they can point to. Practice beforehand because you think it'll be fine. but you don't know what the effect of the medications or maybe a little hypoxia or something's going to happen with the patient.
And
So
it's even
practice
harder for them.
beforehand. Yeah.
Yeah, they're losing their voice, right immediate post-op. Eventually there's things that they can do for the speech generators for that esophageal speech, but establishing that communication method is so important. And then post-op, your airway now, like this is what you have to remember is that airway is the stoma only. There is no more communication between the trachea and esophagus. So if you need to suction that stoma, you need to suction it with some sterile, 14 French catheters. Provide humidity. Sometimes they have to wear devices, HME devices, to provide some humidity. Prevent water from entering the stoma. Like you don't want them just drowning when they're taking a shower. So we really have to educate that patient. Yeah. And then do not allow that patient to be intubated orally or nasally.
It's not going anywhere.
It's not going anywhere.
Yeah.
It has to be through that stoma.
Yeah. If there's no larynx, there's no airway above the neck. Everything goes through the stoma. Mm-hmm. All right, moving on to lung cancer. So the highlights, the number one cause, as we all probably know, smoking. So the first early symptom typically is a chronic cough or a change in the cough. Some other key cues we might see is hemoptysis, dyspnea, unintentional weight loss, or superior vena cava syndrome, that facial and neck swelling that we see.
Right. That was one of our oncological emergencies where that tumor is pressing on the superior vena cava and preventing the venous return going back in. So you're going to see that swelling in the upper body.
I love it how it all relates together. If we understand heart failure, we understand SVC.
That's right. So lung cancer, it shows up late. It spreads early. Sometimes it's one of those that likes to go to the brain.
Yeah. Mm-hmm. And if we have to do, if we have a patient with lung cancer and we go in and do surgery, these patients are always going to come out with a chest tube because we've just destroyed the pleural space.
It all ties together. And one of my favorite things too is I always like to talk about the good lung down, no lung down. So if your patient has had a total pneumonectomy and they have no lung on their left side, you don't want to position them on their right side and the weight of the body compresses the only lung that they have left. So remember that good lung down, no lung down. That's a good saying to remember how to position your patient.
I love that. Yes.
Hey, let's have a commercial break from one of our sponsors, kind of unofficially sponsors.
When a chest tube decides to make a run for it, when the pleural space is suddenly open for business, when your patient just became a human wind tunnel, there's only one product you can trust.
Introducing Vaseline Gauze, the sterile, occlusive hero designed for moments when your shift suddenly becomes a trauma drama.
When it's smooth petroleum sill, Vaseline Gauze provides immediate protection against air rushing into the pleural space. Because nothing says, not today, tension pneumothorax, like a well-placed occlusive dressing.
Benefits may include rapid prevention of air entry, a temporary barrier until you call the provider, and your patient not becoming a flute solo.
Just apply to the site and tape 3 sides, creating a perfect flap valve that lets air escape but stops new air from sneaking in.
Vaseline Gauze for when your chest tube gives up, but you can't.
Vaseline Gauze, sealing the moment so you can save the patient. Another commercial from our unofficial sponsor, ACE Inhibitors. When your heart is fighting high pressure, extra fluid, and a hormonal system in full panic mode, ACE inhibitors step in to quiet the chaos.
By blocking the renin-angiotensin-aldosterone system, ACE inhibitors reduce angiotensin II, the hormone responsible for vasoconstriction and stress.
When angiotensin II drops, the arteries relax, afterload falls, and the heart finally gets to pump without pushing against a brick wall.
And with less aldosterone, the body stops hoarding sodium in water, but may hold on to a little extra potassium.
Side effects may include hypotension, dizziness, the infamous dry cough, hyperkalemia, and angioedema, which is your cue to discontinue immediately.
ACE inhibitors, quieting RAS so your heart can stop fighting for its life.
ACE inhibitors, because sometimes the heart just needs RAS to calm down.
Let's move on to my admittedly least favorite topic, leadership. It's so dry, but we do, we got to talk about it, and we need good nurse leaders. And really, all of us are a leader in some way when we put on that uniform. Nursing is the most trusted profession.
So true.
So leadership is mostly knowing who needs your voice, who needs safety, and who needs you to fill out the paperwork.
Advocacy. Advocacy means speaking up for the patient who isn't being heard. Not the sickest, but the most vulnerable.
Right. That's so huge. Nurse as the patient advocate it's just everything. Let's talk a little bit about core measures too. Core measures are evidence-based steps that hospitals must follow. So we have a sepsis bundle. Sepsis actually isn't a core measure, it's a bundle, but we kind of talk about it with that too. But heart failure has core measures, stroke has core measures, skip, post-op patient, all those core measures, those are things that if we do them, we know that their outcomes are going to improve. If we skip them, bad times.
I think we're seeing a change in that terminology too. I think we're going to move away from core measures and we're going to start calling them quality indicators. So watch, like maybe in 5 years we'll listen to this podcast and be like, what were core measures? And everybody knows quality indicators as like a catchphrase.
Everything changes. When I went to nursing school, there were only 5 rights to med admin.
Oh,
and I came here and I started teaching. I'm like, what? There's 8.5?
Well, you want to hear something even awesomer? When I went to nursing school, we didn't have nursing diagnoses.
Oh, well, I'm so glad we're getting rid of nursing diagnoses. Now we can actually call the problem what it is.
Yeah, that's so last year. Yeah. All right, patient safety. Falls, medication safety, hand hygiene, pressure injuries. The basics are prevent lawsuits and death.
Yeah, skin is the number one thing that people sue for, unless that data has changed. But that's what I had heard throughout my career. And then we have magnet hospitals. I don't believe that we have any magnet recognition hospitals here in Bakersfield.
Yeah, I think we have a couple that are applying in the middle of the
Mm-hmm.
process. Yeah.
So magnet hospitals focus on nursing excellence, strong outcomes, and empowered nurses.
Then we have committees. Committees, the quality of an effective committee has a clear goal. People show up, discussions get done, and that's it. So this would not be your basic nursing program committee that we talk and talk and talk.
Yes.
And talk and talk.
And nothing gets done.
In nursing education.
Yeah, it takes a while for things to get done. So productive committees get things done. Staffing, always,
Speaking of productivity,
the biggest thing, staffing. Acuity, ratios, budget, skill mix. Safe staffing is an ethical duty. It's really, really hard, though, because the hospital system is a business. And depending on where you work, here in California, we are very blessed that we actually have nurse-patient ratio laws. There are times where we might have to go out of them for patient safety if we're, having a huge influx. But the laws are you can only go out of that ratio for, I think, 4 hours before the hospital starts to accrue fines for being out of ratio.
Yeah, and let's talk about these laws and the ratios. From one ER nurse to an ICU nurse, my background is in emergency nursing. We can never shut the door.
Yeah,
we
you
can
don't
never,
get the ratio.
We
when
can
the
never
ICU is
say
like,
we're
we
closed.
can't take that patient, we don't have a bed yet, and you're still drowning down there.
Nothing will piss off an ER nurse more than when you call report on your 7th patient and you hear that your ICU nurse that only has 2 patients is on break. It's like, what is a break? I haven't peed in 4 days. So, yeah. Yeah. So if you're whatever department that you're working on, if you're working in the ER, understand that we don't have the necessary ratios like other departments do.
Right.
But if you're working on the floor in the ICU or something, understand that your poor ER nurse, your patient's going to be dirty.
Right.
Your patient might not have everything done. They're going to be alive. And that nurse is given the best over 100%.
Right.
And they probably haven't peed in 4 days.
So don't yell at them if they didn't label their IV tubing.
Yeah.
And there are times actually where we've gone out of ratio to decompress the ER because the drowning was so bad that it was safer for us to be out of ratio with 3 ICU patients than it was for the ER to be holding 6 of them.
Yep. Because that's super dangerous. Mm-hmm. Yeah, for sure.
But the goal, staffing based off of acuity, that's really the safest thing for our patients. Ties into quality care and prevention of errors.
Yeah, I think, one of the things that we get afraid of a little bit in the hospital system is reporting errors. We really want to report errors. It's not punitive.
Right.
We think it is. And you know what? There are consequences to everything that we do. And so sometimes there are going to be a punishment or something we don't love if we report an error. But how can we fix anything if we don't report it? So reporting errors fixes systems. It's not about blaming, but it's about preventing repeats.
Exactly. We're looking for those system problems. And if you fill out an incident report, you do not chart in the patient's medical record that you filled out an incident report. You chart in the medical record, very objective and factual what you did. But that incident report, it's part of having a high reliability, culture of safety where the organization can actually look at it without fear of reprimand and be able to work on improving it so that those things don't happen again. There are some errors that are reportable, however, like that the facilities have to report.
Of course,
to
yeah,
CMS.
yeah.
But yeah, it's a way for the hospital to look at errors in the system and work on improvement.
When we talked about in leadership, we also discussed some resumes. So as we think about landing that perfect job, there are some characteristics of the perfect resume.
Yeah, 1 page is ideal. You've got a busy hiring manager. For me, with all my years that I did as traveling, I have so much work experience that I listed out. So my travel experience, like my resume when I was a traveler, is a little bit different than mine, now, because I kind of tied some of that in. But you want it to be about 1 page. Your hiring manager is busy. It needs to be professional, relevant, no fluff, no like Elle did on Legally Blonde with her little pink scented resume, which I loved.
It's pretty legit.
I think that'd be pretty great if I got that resume, but we don't want to do that. And I don't know about you, but I was always taught like your education should go first.
Yep. Education first. And, I think that with more and more things coming online and everything else happening, we have some hospitals here that are doing video resumes, video interviews, where you post a video of yourself, or everything is submitted electronically. So we may even get away from what we know now as a resume. It might change a little bit.
Yeah. And your resume is your place where you get to brag.
Yeah. Yeah. It's really hard to brag on ourselves, but I mean, I've met a couple people that like to brag about themselves, but nobody likes them, and nobody's going to hire them.
Right.
Yeah. All right, let's talk about staff development. Staff development, these are the cool kids on the block. They train you and they keep you competent. They keep you safe. They send you all those little reminders to do your health streams or
so
your
annoying,
pathways or whatever.
Part of the requirements, right, to keep the doors open and for us to have a job. And also, we don't want to treat leadership as our enemy, right? Like, we need to work with them. And I would just say, remember, like your nurse manager, they don't necessarily have control over every single little thing. They're hearing stuff from the bottom and from the top and trying to find that balance and do what's best within their, scope to take care of those patients.
Yeah, for me and my personality, that is the job I would never want.
I couldn't do it.
Nope, I do not want that. You're squished.
Yep.
Yeah, upper administration is telling you to cut costs, and the people that you work with and work for are telling you, we need this, we need that, and you are stuck. That is a no-win situation right there. Yeah, that's stressing me out,
But
Chelsea.
I do love it when I see my nurse leader in their high heels walk in a room and help clean a patient when they're really struggling.
That's a good nurse leader. Yep. Yeah, that is a good nurse leader. You're stressing me out, Chelsea.
All right. Well,
I think it's time for a commercial.
Nurse Leader Edition commercial break.
I love it.
Brought to you by our unofficial sponsor, who could pay us if they would like to.
Yes, anyone. Feel free.
Yep.
At Just Heart Health Systems, we understand nurse leaders face a unique kind of stress.
The kind that comes from 3 call-outs, 2 feuding surgeons, and Joint Commission wandering the halls like a horror movie jump scare.
And when the staffing matrix looks like a crime scene and your committee meeting could have been an email from 2018,
there's lorazepam.
Lorazepam offers anxiolysis for acute stress. But remember, never give it to a patient with unexplained altered mental status, unexpected hypoxia, rising ICP, or any condition where sedation can mask deterioration.
In leadership terms, don't sedate someone who's crashing. Fix the cause first. Same applies to your staff.
Side effects may include finally taking a deep breath, feeling less emotionally attached to the staffing grid, the sudden ability to say, "No, that's unsafe," calmly, and temporary inability to tolerate nonsense.
Other leadership side effects may include realizing half your stress wasn't the job, it was the meetings, whispering, "I don't get paid enough for this," with a peaceful smile, and refusing extra admissions like a spiritually awakened bouncer.
Lorazepam, because sometimes the emergency isn't medical, it's the staff meeting. Next up is Unit 10, Hematology.
Welcome back to the Just Heart podcast. Hematology. If the bone marrow's tired, the whole body files a complaint.
Yeah. So if we are looking at the bone marrow, then it makes red blood cells, and those carry our oxygen. White blood cells are responsible for immunity. Platelets are clotting, and if production tanks, we see a patient that's fatigued, risk for infection, and bleeding.
That's right. Chemotherapy can cause all those things in our patients, right? We see this a lot with our cancer patients, especially those that have cancers of the blood. Fatigue, pallor, which means pale, bruising, bleeding, fever, often the first, maybe the only sign of infection in your immunocompromised patient. Bone pain from, that overwork and swollen lymph nodes.
So let's look at some labs. So what we're going to look at is our complete blood count. We're going to look at our coags, PT, PTT, INR. Check out the calcium, look at the uric acid, and a bone marrow biopsy for a diagnosis.
Yes, bone marrow biopsy is for diagnosing your hematology cancers, and those cancers are already automatically stage 4. And then aging, of course, we got to talk about age-related changes. Older adults have a lower marrow reserve, so slower immunity, increased anemia, and increased risk for clots.
Yeah, they might just walk around with a constant state of anemia.
Yep.
Yeah. Major disorders of the hematologic condition, leukemia. This is where we have too many non-functional white cells. So the white cells aren't working effectively. So infection, anemia, bleeding, bone pain. Lymphoma.
Painless enlarged lymph nodes, plus B symptoms, fever, night sweats, weight loss.
Thrombocytopenia.
Low platelets, bruising, petechiae, and bleeding risk.
How about lymphedema?
Ooh, blocked lymph drainage, chronic swelling, need to protect the skin. We can also see lymphedema occur in what, Lisa?
Breast cancer.
That's right, with a mastectomy with node involvement. Also a limb alert on that arm, just like a limb alert for the arm with an AV fistula.
Yeah. And multiple myeloma.
Bone destruction, fractures, pain, hypercalcemia, renal issues, and ecchymosis.
Every heme disorder circles back to infection, bleeding, fatigue, and bone pain.
And it is time for a brief commercial break for someone who does not sponsor us.
Neupogen. When your patient's ANC is so low, you're afraid lukewarm handshake might take them out, there's Neupogen.
Neupogen, the colony-stimulating factor that busts into the bone marrow like everybody up, we've got neutrophils to make.
It stimulates neutrophil production, giving immune systems the backup singers they desperately need.
Basically, it tells the marrow, enough resting, we've got infections to fight.
Common effects may include bone pain because the factory is open, a low-grade fever, and the urge to brag about your absolute neutrophil count, ANC, like it's your credit score.
And remember, bone pain is actually good news. It means the marrow is finally doing overtime.
Neupogen. It's for neutropenia, chemosuppression, or plain old marrow burnout.
For anyone whose immune system is clocked out, overwhelmed, or asleep at the wheel.
Neupogen. Giving your immune system the comeback tour it didn't know it needed. All right, moving on. Burns and skin cancer.
So Unit 12, we're going to make this a little bit short, spicy, painful, just like stepping on a hot curling iron, because we just did burns, and there's so much. I think my PowerPoint was like 135 slides.
Way too much.
So since this is for the final review, it's going to be a little bit briefer. Next season, we'll do a full burn lecture.
Yeah, it'll be legit.
Yeah. So burns are all about fluid shifts, airway risk, pain, temperature, and tissue destruction. Nothing behaves normally, and the body goes full drama mode.
Yeah, so let's talk about airway burns. If the face, neck, or chest is involved, airway is always the biggest question mark. Smoke, heat, swelling, the airway gets mad before the skin does.
Fluids. Early burns, massive fluid loss. The albumin, they have no skin. Everything leaks out. Albumin leaks out. It takes the fluids with it. So we've got to give the patient lots and lots of fluids. If the fluids are helping, we're going to see, hopefully, our vital signs kind of stabilizing. And the biggest thing is that urine output.
Yeah, consensus
Adequate
formula.
urine output. Yep.
Chemical burns. So gasoline, acids, alkalis, whatever it is, step one is always decontamination. So the burning stops before treatment begins.
Right. We have to know what they did for that chemical burn in the field, because if they haven't irrigated it with water for at least 20 minutes, the burn is likely still occurring.
Yeah, we need to know what it was. Material safety data sheets or those little codes on the truckers. We need to know what that is.
Temperature regulation. So severe burns can make the body run hot or cold. It can't regulate itself normally, and we're losing, especially if you have loss of that subcutaneous tissue.
Yeah, for sure. Yeah. So skin cancer, this was also part of our talk. Skin cancer is basically, is this spot trying to ruin my life, or is it just a freckle? Look for changes in the shape, color, border, or behavior. This is where we use the ABCDE vibe.
Yeah, so in summary for Unit 12, burns, protect the airway, lots of fluids. We want to know what those burn agents were. Treat the patient. And a lot of times the medications that they're on for antibiotics just depend on what they're growing. They almost always end up growing Pseudomonas or...
Sure do.
Mhm.
Yeah. And skin cancer wants attention before it becomes a problem. So you need to slather on that sunscreen, stay out of the peak sun times, and take care of your skin. Okay, that's Unit 12. Short, sweet, done.
And it's time for a commercial break.
Is your patient's burn wound acting like it's auditioning bacteria for a Broadway musical? Is every square inch threatening to become its own petri dish?
Meet Silver Sulfadiazine, the antimicrobial cream that strolls in, spreads out like a VIP lounge, and tells bacteria, not tonight, sweetie.
With broad antimicrobial coverage, SSD keeps burn wounds cool, clean, and lightly frosted like a donut in the ICU.
Side note, it may also stain everything it touches a mysterious gray purple. Skin, gauze, sheets, your soul. But honestly, that's just color coding for infection control.
And as always, if your patient has a sulfa allergy, silver sulfadiazine is a very firm absolutely not. Silver sulfadiazine, classy antimicrobial protection.
With a hint of purple mystery.
All right. GI, liver, and pancreas.
Taking it back to where the Just Hard podcast started, episode 1, GI, liver, and pancreas, the holy trinity of drama.
And don't worry, we're keeping this quick. If you don't already know this material, this recap is not going to save you.
The GI energy, inflammation, absorption issues, pain, bleeding, obstruction, and leaks. Everything is either moving too much, not moving at all, or coming out places it should not be.
When the liver struggles, everything gets chaotic. Fluids, brain function, coagulation, kidney, it's never just a liver problem.
Right. When the liver can't filter toxins, the brain is the first to complain, and it does so dramatically.
We also have the pancreas energy. The pancreas gets mad, so then we have pain, rest, fluids, stop eating, let it chill, but not for too long. The pancreas gets happier, and then you'll know.
You'll know. The enzymes, if the gut can't digest something, you have to replace what's missing and carry on. So sometimes they need some pancreolipase. They sponsored us unofficially on our first episode.
Definitely go
And the
listen to
biggest
that
thing
one.
that I always worry about with pancreatitis too is nurses have to remember to look at the patient's back.
Oh, yes.
Mhm.
Yeah, posterior bleeding because they could have hemorrhagic pancreatitis.
Yep. And then surgery is used a lot for our patients with GI, whatever may be going on, especially for the GI cancer. Surgery is the #1 treatment. So gut surgery, they always lose a lot of fluids, any type of abdominal surgery. So protect the airway, protect the incision, teach them splinting so that they can move. The bed is what kills you. Patients need to get out of bed and they need to walk.
Yes. Okay, it is time for our commercial break. So this is rifaximin, the liver edition.
Does your patient's gut keep sending ammonia to their brain like it's Amazon Prime? Is their liver so overwhelmed that even protein is turning into drama?
Say hello to rifaximin, the antibiotic that stays in the intestines and tells the bacteria, stop breaking down protein into ammonia. We're not doing that today.
That's right. Rifaximin doesn't wander the bloodstream. It stays local, reduces the bacteria responsible for ammonia production, and helps the liver patient keep a clearer head, literally.
Think of it as the gut's boundaries coach. Fewer bacteria means less ammonia, means less cognitive chaos.
Side effects may include improved clarity, a calmer GI tract, and your patient no longer asking you the same questions 6 times in 10 minutes.
Rifaximin, calm the gut, clear the mind. All right, endocrine.
Oh, I like this almost as much as leadership. So welcome to Unit 13, where tiny glands ruin everybody's day.
The thyroid controls metabolism, temperature, energy, mood, and heart rate. If it's overworking, chaos. If it's underworking, hibernation mode.
So hyperthyroidism, everything speeds up. Hypermetabolic state, high heart rate, high metabolism, high temperature, anxiety, diarrhea, sweating, drama. Calm the environment, low stimulation, calm, quiet environment. Try to prevent a thyroid crisis by giving the thyroid 0 reasons to freak out.
So hypothyroid, everything slows down. Patients are cold, tired, bradycardic, constipated. I could live in this blanket forever, even in the middle of a hot Bakersfield 110-degree summer.
Yep. Myxedema crisis. That is your hypothyroid emergency. When the hypothyroid goes nuclear, cold, slow, barely responding, we need to support the patient's airway, warm them, and make sure we keep that heart rate and blood pressure up at a rate that is sustainable with life.
So there's a conflict between amiodarone and the thyroid gland. Amiodarone is thyroid drama in a bottle. It can push you toward hypo or hyperthyroidism, but an elevated TSH means the gland is slowing down.
Right, because it's got that iodine in it, the iota.
Yes, yes.
Let's talk about the parathyroids. Parathyroid hormone regulates calcium. So too much parathyroid hormone, you're going to have high serum calcium levels, predisposing you at risk for stones, bones, and groans, because you could have those pathological fractures because your body is taking all your calcium out of the bone bank. Whereas too little, you could have low calcium, twitchy, crampy, tingly. NCLEX, I believe, probably loves to talk about the Chvostek's sign.
Yes, yes. So hypocalcemia, tingling, spasms, irritability, and the whole body acting like the electricity bill just doubled.
Hypercalcemia, sluggish, thirsty, weak, dehydrated, constipated, and the bones filing HR complaints.
Yeah, so in summary, thyroid controls the pace.
Parathyroids control the calcium.
Endocrine, small glands.
Big energy. And it's time for a commercial break.
There was a time when your patient woke up with purpose, when mornings felt alive, when metabolism and motivation were still speaking to each other.
But now, life moves in slow motion, not the enchanting kind, the exhausted, heavy, why does getting out of bed feel like climbing Everest kind.
And that's when levothyroxine appears, not as a medicine, but as a reunion. A second chance between body and energy, between metabolism and meaning.
To work, levothyroxine needs commitment. Take it first thing each morning on an empty stomach with water and intention. No coffee, no breakfast, just you and the promise of a new beginning.
And for some, only the brand name can bridge the distance. It's not a preference, it's a destiny. Their thyroid can tell the difference.
And once it starts working, you'll know, because suddenly the world speeds up again, and this time it feels right.
Levothyroxine, because some love stories
deserve a second chance. Welcome back to the Just Hard podcast. We are going to tackle neuro for our final review. We already lived through this in episode 2, so this is the Spark Notes version of the Spark Notes version.
Neuro is all about function, weakness, sensation, reflexes, and pressure. If something changes suddenly, that's your red flag.
Multiple sclerosis, or MS. MS, unpredictable flare-ups plus quiet periods, nerves get irritated and demyelinated. Everything becomes intermittent. The motto is rest, pace, protect energy.
Amyotrophic lateral sclerosis. This is when your upper and lower motor neurons degenerate together. We see weakness, speech issues, respiratory decline, but the mind stays sharp, which is cruel and poetic.
Guillain-Barré syndrome, or GBS. Ascending neuromuscular paralysis. The weakness starts low and it moves up. Ascending, that's the ticket. Most of neuro is slow. GBS is fast. Biggest concern when it hits that diaphragm and you lose your respiratory, so breathing.
Myasthenia gravis. Muscles fatigue with use. Rest helps. Effort makes everything sloppy. Our speech, our swallowing, our eyelids, our breathing. Basically, everything is too tired to function. That's the whole vibe.
Brain tumors. Location determines symptoms. Frontal lobe drama, personality changes. Cerebellum drama, coordination issues. Parietal drama, sensation chaos. It's like real estate. Location is everything.
Increased intracranial pressure, or ICP. The skull does not negotiate. If pressure rises, something gets squeezed. Elevate the head, protect the airway, and keep the brain as calm as possible.
I love talking about increased ICP. I think that hopefully we've got them ready for fourth for the ICP, taking care of those patients. A lot of times they're a one-to-one when they're having that acute change, and keeping that neck in neutral alignment. That's what separates a good nurse, right? Like when you walk by a room and the patient's all slumped in the bed and their like necks crooked and falling over. But yeah, you want to keep their neck in neutral alignment for that venous drainage. and keep the brain calm. This is the one time that we actually do not cluster our care, right? Because every time we do something to that patient, that ICP shoots up.
Yeah, this is where we need to use all those funky looking airline pillows that everything have. Have you ever, how do you actually wear one of those?
I do.
Where does the snap go, or does the opening go in the front or the back, or does it support your chin or your neck or the?
I guess it depends. If you're stuck in the middle, just
the
keeps you from falling
drama?
over on the other person. Yeah. If I'm on the
Okay.
window, I sleep against the wall. One time I scheduled a trip after I worked night shift, and I scheduled a red eye thinking it'd be perfect, and my flight was delayed 8 hours. And so I fell asleep at the gate, and I woke up when a different flight was boarding, and I was drooling.
That's fantastic.
It was so bad.
Did you drool on your pillow?
Yes.
That's fantastic.
Yeah, I was great. I was probably snoring too. I was so tired.
People just don't understand the life of a nurse.
Yeah.
Night shift is, where people do.
Yeah, I did my time on night shift. I can't
Same
do it
girl.
anymore.
Same girl, same.
Yeah.
All right. Unit 14 summary.
Nerves get tired, muscles fail, pressure rises.
And changes are always a big deal.
Neuro keeps receipts. And now it's time for yet another commercial from someone who also doesn't pay us.
There was a time when muscles moved with grace, when eyelids rose effortlessly, when breathing felt natural, when swallowing wasn't a negotiation.
But somewhere along the way, the neuromuscular connection faded. Signals grew faint, acetylcholine slipped away, and the body forgot how to respond.
And then, from the shadows, a small tablet appeared.
Mestinon, not a cure, but a chance, a spark, a second shot at function.
It holds acetylcholine close. It keeps it from slipping through the cracks, extends the moment, and whispers to the muscles, "Try again. I'm right here."
Suddenly, eyelids lift, words form. Breathing deepens, and the body remembers what strength felt like.
It's getting awkward. But timing matters. Give it late, and the muscles have already walked out. Coat on, keys in hand, saying, "You should have called earlier."
Give it on time, and you might just witness the most beautiful reunion between nerve and muscle since the first synapse fired.
Mestinon, because sometimes the body just needs a moment to remember how to move.
Mestinon.
That was awesome.
All right. That was our final review podcast. So we just wanted to say a thank you for listening. Like, subscribe, follow. Maybe one day somebody will pay us. But thank you for a wonderful semester. Thank you for being engaged and letting us be your instructors. Thank you for showing up, for going through the chaos with us, and giving the semester every ounce of energy you had left, even on the days where you barely had any.
You all worked hard. You asked real questions, you pushed yourselves, and you kept coming back for more. Even when the content was wild, the exams were spicy, and the simulations were, simulations.
We're proud of you. We really are. Not just for making it through the material, but for becoming the kind of humans we trust at the bedside one day.
We mean it when we say you're our future coworkers, our future colleagues, the people who'll be giving report with us at 7 o'clock while we all question every life choice that led us to this shift.
Yeah, and when you're working with me as my coworker, just call me Chelsea. You got to drop the Professor Justice. It's so hard sometimes.
Yes.
But yeah, follow, subscribe, share the podcast, not because we need the numbers, but because someone out there might need a laugh in the middle of their own semester.
Yeah, we're not into titles here, and when we're colleagues, we're just your colleagues, and so please treat us as such. We're super proud of you, and wherever you go from here, clinical, boards, nursing school, nursing life, we're rooting for you every step of the way.
Thank you for a great semester, and welcome to the profession.
And don't forget, you can do hard things.
It's just hard.